All right. So everyone can hear me. I'm assuming we're good. So my name is Jane Bischoff. I'm a pediatric psychiatric pharmacist. That's where I spend most of my time. And I'm just here to talk a little bit about ADHD, the medication specifically, and some approaches to the stimulant shortages that we've been seeing over the past few years. I have no conflicts of interest to disclose. I will use generic names whenever possible, but the brand might be referenced if appropriate. I have no endorsements of any, or I do not endorse any particular medication over another. It's just easiest to tell them apart if you include the brand name. There will be no mention of off-label use of medications in this presentation. So as a pharmacist, I am not a NP, I'm not a PA, I'm not a physician or a psychologist. So my specialty isn't diagnosis. My specialty is more in the treatments and kind of finding the right drug for the right person. So I'm talking again about treatments, not diagnosis. I understand that ADHD isn't a standalone disease. It's frequently in combination with anxiety disorders or conduct disorders or other psychiatric disorders. So I understand that you don't get to just treat ADHD, but for the purposes of this presentation, that's kind of what I'll attempt to do, and that's how I'm going to gear the presentation. Here are some abbreviations. I apologize, this was not on the slide deck that was sent out. I'll do my best to make sure that I am saying the full name of whatever I'm abbreviating now. Here are the learning objectives. I just wanted you to look at the similarity between the 3 ADHD guidelines and identify some specific qualities in methylphenidate and amphetamine-based dosage forms that could be beneficial for certain patients. Finally, I think that the drug shortages are probably not going away, so I just wanted to, hopefully by the end of this, you'll have a strategy to help navigate it. As an outline, first I'm going to go over the diagnostic criteria for ADHD. Then I'll review the guidelines, landmark trials. I'll go into the current medication formulations and different medications available. Discuss how to navigate shortages, and then a case presentation if there is time. So according to the Diagnostic and Statistical Manual of Mental Disorders, version 5 text revision criteria, ADHD is a persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning and development. So the inattentive part is, difficulty staying on task, kind of having your mind in the clouds, being easily distracted and sidetracked. And then the other component, the hyperactivity and impulsivity, is, the fidgeting, talking excessively, maybe blurting out answers when you're not supposed to, maybe interrupting others as well. And several symptoms need to be present before the age of 12 and in 2 or more settings. Of course, the symptoms should not be better explained by another mental disorder. In terms of ADHD guidelines, we kind of have the 3 most recent guidelines that have been put out, and a lot of them are endorsed by different governing bodies of ADHD or pediatrics in general. So the Canadian guidelines have certain recommendations for specific drugs. So they first say long-acting psychostimulants. That would be something based on, an extended release form of amphetamines or methylphenidate-based drugs. They also recommend atomoxetine, which is a non-stimulant medication, and they have some weaker evidence for the shorter acting psychostimulants. The NICE guidelines are, these are British. They do recommend stimulant use second line unless impairment is severe. These guidelines rely a lot more on behavioral techniques. and different interventions that are non-pharmacologic, but they do acknowledge that stimulant use is effective for treating ADHD. The American Academy of Pediatrics kind of gives this blanket recommendation for FDA-approved medication, which is probably smart because there's new formulations coming out every year. So they're really just recommending something that's been approved by the FDA for ADHD. They also have a big emphasis on parent and caregiver training and behavioral management. So they divide up the recommendations by age, but PTBM is a big portion of the treatment recommendations. Overall, all of the guidelines recommend treatment over not treating. So they don't recommend, watchful waiting. They do recommend treatment of some sort right away. The MTA study is the multimodal treatment study of children with ADHD. And this found that for ADHD specific core symptoms, that medication alone or medication with behavioral therapy was superior to either regular behavioral therapy or community care. Community care being basically seeing your provider, once or twice a year, and maybe getting, a stimulant prescribed, but nothing as intense as the behavioral therapy that they were doing in this study. Taking medication did slow growth by about 3/4 of an inch and 6 pounds. The study was only really controlled for, and can only really show that the growth rates were slower at the beginning of therapy. So the first 14 months when they were all divided into these 4 groups. Follow-up studies have kind of found conflicting things, but the growth rates themselves had normalized by the end of 3 years. Children with ADHD showed significantly higher than normal rates of delinquency and substance use after 3 years. And that's whether or not they had behavioral treatment, behavioral plus medication, or any other treatment. And the conclusion that they drew from this was that ADHD drugs by themselves, although they are frequently abused and diverted, they will not cause a child to be more or less likely to develop a substance use disorder. All right. So these are just generally the medications that are recommended, kind of a combination of all of the guidelines. So first line, they typically recommend methylphenidate and derivatives of that drug, which I'll go into it a little bit further. It's typically recommended over amphetamine and derivatives. However, both of them can be used for ADHD. The stimulants increase dopamine, increase norepinephrine availability, and have that stimulating effect, which is why they're called psychostimulants. Then we have some second line agents that are non-stimulants. So they're not controlled substances, not considered abusable. And these include atomoxetine and viloxazine. For impulsivity and hyperactivity, some people will add on the guanfacine extended release or clonidine extended release. Again, these are more for using in combination with one of the 4 drugs or drug categories above, but they could theoretically be used on their own. In terms of the severe and most common risks of treatment, there's a box warning for abuse, misuse, and addiction, not to mention overdose is always a concern. It does increase the heart rate and blood pressure, so it does have those cardiovascular effects and could be a concern if someone has pre-existing cardiac abnormalities. The growth suppression we did touch on at the beginning. It's definitely suppresses the growth rate at the beginning of therapy. It might normalize, if they are taking it less than 50% of the time, if they take drug holidays, which is why those are commonly recommended. Priapism is a very rare side effect that can happen from these medications. It's a prolonged erection for more than 4 hours. I'm sure you've seen commercials that are concerned about this and say, like, if you have an erection more than 4 hours, go to the emergency room. This is one of those drugs that can cause it. And it is a medical emergency. However, again, the frequency isn't defined. It is not very common. There are the psychiatric and behavioral effects that can be a severe side effect. So it can cause some aggressive behavior, mania, or even hallucinations. These are generally pretty serious and pretty apparent. It isn't a slow, kind of a slow onset. It's very clear that their behavior is different. Some common side effects are insomnia, decreased appetite, headache, and dry mouth. And in general, these effects are dose dependent. So starting at a lower dose and going slowly is kind of the trend in pediatrics in general. But certainly in this, with these two types of medications, we would want to for sure be looking at that insomnia and decreased appetite and look at that as a sign to change the dose. All right, so the first medication that I'm going to talk about is methylphenidate. So you'll see the theme here with methylphenidate and amphetamine-based dosage forms, that it's the same drug, just in different packaging. So first we have the immediate release tablets. You can see that with the turquoise line on the left. So it's quick on, this is a concentration versus time graph, very crudely drawn. It's a quick onset, within an hour, and then it lasts for a few hours and wears off. We also have extended release forms. Extended release is something that will have a slow onset and slow offset. So it's sustained over the day and then wears off. So ideally, you would want a drug that's a combination of the two of them, which would look like something that's in the middle of those, where you're getting this quick onset, but you're also getting this sustained therapeutic response. The little line at the bottom of the kind of parallel to the x-axis is not super important. It's just acknowledgement that some people do have tolerances to the drug, and it might be present in the body, but that doesn't mean that it's enough to cause some noticeable effects. So the drug might still be in your system, but it, towards the end of the day, it might not be enough to keep you up at night, which is a good thing. All right, so I've kind of split up the methylphenidate formulations into different extended release forms, and I'll try and hopefully describe how different they are and how they can be used to treat a patient more efficiently. So the monophasic, or the quick on or slow on, slow off drug is Metadate ER. It's been generic. It came out in, I think, 1987. So it's been around for a while. It is something that has that onset of 90 minutes, and then will last 3 to 8 hours. So for most people, you do need to function within the first 90 minutes of your day. So this drug typically isn't given alone. Maybe you have a slow morning and you really don't need that extra help. But for most people, they will end up adding on immediate release tablets to give you that burst at the beginning. In terms of biphasic, or having two phases, so if you combine those immediate and extended releases into one capsule or tablet, in order to make a new drug, and again, these are all same drugs, different packages, you have to change around the proportion of immediate release and extended release. So all of these will have the same onset and have that long-lasting effect throughout the day. And I'll show you. So this is just kind of a graphical representation of, all immediate release in turquoise at the top, down to all extended release, or the pink at the bottom. Most of these extended release formulations fall somewhere in between. So you can see that the Ritalin LA, it's 50% immediate release and 50% extended release. So that's quite significant. So that's generally better for people who might have a busier first part of the day or might have difficulty just with the first part of the day in general. And then you kind of see how the immediate release portion decreases as the extended release portion increases. And it would kind of change the shape of the dose response curve. In terms of clinical significance, I know that a lot of formularies do not actually cover each and every form. So that can be a challenge. Sometimes there's a clinically significant difference. For some people, there may not be, though. They may not notice the difference between Ritalin LA or Metadate CD. And if they have to switch because their insurance only covers one or the other, it can be tolerated. And then one thing to mention is that you could always add in an immediate release bump, you know, in the middle of the day or towards the beginning of the day to kind of make up for the change proportions in immediate and extended release. In terms of triphasic or kind of having three bursts of energy or bursts of drug, we have Concerta, which is generic, but it mimics taking one of the immediate release tablets 3 times a day. The advantage of taking one tablet is you only have to take one tablet a day. And it appears to be a little bit smoother with the way that you start feeling the effects in your body, and it may be more helpful towards the end of the day. Other forms of extended release methylphenidate include the Daytrana patch. I do not believe there's a generic, but it is applied, I mean, obviously to the skin 2 hours before the start of the day. So it does take a while for it to start releasing in your body. It can be worn up to 9 hours and lasts up to 10. One kind of difficulty with this is that it's rare, but it can cause permanent discoloration of the skin. So some people just tend to stay away from it for that reason. However, the Daytrana patch or just the patch in general might be a good option for someone who either can't or won't swallow tablets. For liquid formulations, we have one of the liquid formulations is it has immediate release as only 20% and extended release for the rest of the day. So very little released at first. The way that these are supplied is they're supplied as 30-day bottles. So depending on your dose, that's how many milligrams you get in a month. So you end up needing to reconstitute an entire bottle because it comes as powder to get your dose. So you have to, instead of, counting out an extra number of pills, if their dose increases, you have to get an entire new bottle. That can be difficult, and a lot of pharmacies might not want to keep it in stock because what if someone never uses, one strength? It would be like wasting like a whole month's of medication if it expired or was unable to be used. Jornay PM is one of the newer formulations. It's actually taken in the evening, and 5% of the drug is released in the first 10 hours, and then it just starts slowly releasing in the morning. So that can be an option for kids who might have some difficulties, right when they wake up in the morning. Certainly for kids who need to take that drug as soon as they wake up, this can be a good solution, is the Jornay PM capsule. There is a drug in development, so no guarantees that it'll come out, but it does have 3 different release layers, and it's a dexmethylphenidate tablet, and it might last up to 16 hours. So that could be useful, maybe more in adults, but we shall see. So when discussing dextro and levo, basically when you make a drug, you end up making a right-sided and a left-sided molecule when you're making Adderall and methylphenidate, or amphetamine and methylphenidate. The right-handed form is the one that's actually more potent, that has most of the therapeutic effects, but you don't get one without the other. So they can manipulate the chemical process to kind of get different proportions of this right-handed molecule and left-handed molecule. And I'll show the proportions in the slides, but for our purposes, all you need to know is that we like anything that starts with dex. All right, so dexmethylphenidate, again, this is the right-handed molecule, the one that we like more. It is, a conversion would be like 2 to 1. So you would use half the dose of methylphenidate if you were converting someone who maybe wasn't able to get methylphenidate to dexmethylphenidate. There is a new drug, Azstarys, that actually has a different way of being extended release. It's a prodrug, meaning that your body has to activate it, which makes it less abusable because you can't crush it up or snort it or take it all at once. And it has that abuse deterrence, and then it also has that immediate release dexmethylphenidate in there. Again, lots of same drug, different packaging. That theme's going to continue with the amphetamine-based drugs. So we have mixed amphetamine salts. These are probably the most common. We have mixed salts of single entity amphetamine, and that one, my day is. I learned that it means my day is 16 hours, and that's where they get their name from. Other than that, I don't have much experience or anything else to mention about that. There's amphetamine sulfate, which is a 1-to-1 ratio of that right-handed and left-handed molecule. And then there's lisdexamphetamine, which converts into that dexamphetamine, that right-handed molecule. And then just pure dextroamphetamine, which was some of the earlier ADHD medications, Dexedrine, Spransel, Zenzetti, and Procentra. So as I mentioned, the mixed amphetamine salts are the most prescribed agents from this group from amphetamine-based compounds. The immediate release lasts 4 to 6 hours. The extended release lasts 10 to 12 hours. And again, the extended release does have immediate release formulations inside. They're all generic, very predictable kinetics. You know when it's going to start, stop, everything like that. Easy to dose. Probably, I would say that most people know the dosing of this drug more than most other stimulants. It can be poured into food. You can crush tablets. However, it does definitely have that abuse and diversion potential. One thing I wanted to mention is that absorption can be delayed if you have a high-fat breakfast or high-fat meal with it. In general, that doesn't have to be clinically significant since most people have a similar daytime routine of either eating breakfast or not eating breakfast when they take their medicine. So that's generally controlled for by a daily schedule or routine, but if for some reason the routine changes and they start eating a high-fat breakfast, you might want to adjust the dose at some point. So lisdexamphetamine, the brand name is Vyvanse, which is probably what it's more commonly known as. It is generic. It just went generic in the last year, which is great because it is a very highly utilized medication. Several generic companies were approved to produce it. So I think 4 were approved to make the generic, which is more than they usually approve. And unfortunately, demand has exceeded supply. So insurance companies are now preferring the generic, but the generic production can't keep up with the demand. There's a unique mechanism of action, which makes it desirable for a lot of prescribers because it has that low abuse potential. It's absorbed through the GI tract into the blood. And then your blood actually has this enzyme that cleaves off the lysine residue and then slowly releases dextroamphetamine throughout the day. So it's a really unique mechanism of action, but it means, again, that you can't crush it, you can't snort it, you can't take it all at once. Your blood is the rate limiting step to it being released. You can pour the capsule into food, which is very convenient. Just a little note, if you divide the dose by 2.5, you will get the equivalent of the dextroamphetamine dose. So 70 milligrams of lisdexamphetamine will convert to 30 milligrams of dextroamphetamine. All right. Dextroamphetamine, again, that's that right-handed molecule that we like. So generally switching from the mixed amphetamine salts or Adderall to dextroamphetamine, you cut the dose in half. Same thing with the methylphenidate. Now, if you'll recall, Adderall is actually 3/4 dextroamphetamine and 1/4 of that levoamphetamine. So you might think, well, why wouldn't you just, change it to, from 10 milligrams to 7.5 milligrams of the dextroamphetamine. It's a little bit more complex than that. So there are interactions between the dextroamphetamine and levoamphetamine molecules. So it isn't as much of a clear switch. So generally it's cut in half and then adjusted if needed, which is, so it's an approximate conversion is what I'm trying to say. Also, a lot of people might not be able to get the dosage form that they're looking for if they just do a 3-to-1 switch. It may be better tolerated in some patients. It is that right-handed molecule that we prefer. And it might be to the point that they don't even need as much as half of their Adderall dose. Unfortunately, it has the same abuse, diversion potential as all the other formulations. There is a dextroamphetamine patch. It's the newest formulation and it can be worn for up to 9 hours. Now we'll move on to the non-stimulant medications, atomoxetine and viloxazine. These two are kind of second line just for people who maybe can't tolerate stimulants, or if even at the lowest dose they are unable to tolerate it, they get agitated, uncomfortable, can't sleep, sort of thing. So there's just an alternative that can be prescribed. So in terms of severe and most common risks of treatment, we have the cardiovascular effects, which is unfortunate because you also have those with the stimulant dosage forms, but you have to be careful if there's pre-existing cardiac abnormalities. Box warning for suicidal ideation. There are some drug interactions with atomoxetine where if you're taking fluoxetine or bupropion, that will increase the exposure of atomoxetine. Generally, drug-drug interactions are controlled for by just prescribing one med at a time and changing one med at a time. So if they are interacting, usually you're keeping one dose steady of the other, and the other can be adjusted based on clinical response. Atomoxetine does have a few extra warnings on it, and again, it is an older drug than the viloxazine, so not to say that the viloxazine doesn't cause this, but atomoxetine does have those warnings for growth suppression, hepatotoxicity, priapism, and then exacerbating psychosis or mania. Some of the common side effects are drowsiness, insomnia, decreased appetite, nausea, headache, and a dry mouth. Again, these effects are dose dependent, so can likely be controlled for by just prescribing a lower dose. But for some people, that might be pretty uncomfortable. All right, looking more at atomoxetine. So it is a non-stimulant. It's a selective norepinephrine reuptake inhibitor. So it just increases the availability of norepinephrine. Unlike the stimulants, it has a little bit of a delayed onset of action. So it can take like 2 to 4 weeks to really see the full effects. Some people might see effects sooner though. Unfortunately, if someone can't swallow pills, this is not the medication for them. It is specifically recommended that you do not open the capsule as it can cause ocular irritation. The dosing is very, very specific, along with the dosage forms, 10, 18, 25, 40. They don't make a 20 or 30 milligram dosage form. I always refer to the package insert just to look at the kind of the very specific directions in order to dose that drug. Fluoxetine is the newest ADHD drug, and it's a non-stimulant, similar mechanism of action as the atomoxetine. In general, all brand name medications will have a manufacturer coupon on the website that can be used to help reduce copays. It has a similar place in therapy as atomoxetine. I did find one study that said it might have a quicker onset and some favorable side effects. This was based on a 50-person unblinded study. So I didn't take it too seriously, but however, it was funded and written by people who had absolutely no financial ties to either medication. And they were actually just following patients who had to follow insurance step therapy where they did have to have a 1-month trial of atomoxetine before trying the newer drug. This one you can sprinkle into applesauce. So if you have someone who can't swallow pills, that is just fine. Finally, I'm going to talk about the guanfacine extended release and clonidine extended release that can be added on or used alone for ADHD, generally to help with impulsivity and hyperactivity. Severe and most common risks of treatment with these medications are the cardiovascular effects. So it's the opposite of the other ADHD drugs that are going to raise your blood pressure, raise your heart rate. This can actually decrease your blood pressure. It can cause dizziness and drowsiness. And as with every medication I've talked about today, it can also cause a headache. These drugs work very, very similarly. There's a few key differences. Guanfacine is only mildly sedating because it doesn't cross the blood-brain barrier, but the clonidine is a little bit more sedating, generally taken in the evening. Again, both of them could be used on their own, but are typically used in combination with a stimulant or non-stimulant. The guanfacine dose is actually 10 times the dose of the clonidine because it doesn't cross the blood-brain barrier. I know we talked about drug holidays earlier in this presentation. With these medications, since it does affect blood pressure and you need to build up a tolerance to it in order to increase the dose, you would not be able to take a drug holiday from this drug. One thing I just wanted to mention is to plan ahead, certainly for drug destruction, basically anything other than flushing it down the toilet. Certainly when you're prescribing a lot of these controlled medications, it's important to be talking to the families about how to destroy it, whether it's a drug disposal envelope, if you have a drug take-back event, if there are pharmacies or police stations in the area that are willing to take old medications. And then also to keep medication in a secure location. So of course, stimulants, although we'd like to think the best of our family and friends, they are kind of something that you might find missing more so than your statin or your other blood pressure medication. So it's important to keep it in a secure location. Now I'm going to talk about the shortages. And I liken a stimulant shortage to the toilet paper shortage at the beginning of COVID, where there's a lot of demand and not enough supply to make up for it. So one part of it is, of course, the increased demand. There were a ton of increased prescriptions for stimulants and non-stimulant drugs for all groups, but specifically for younger adults, so ages 20 to 39, and in female patients, 25% increase for the stimulant use and 59% increase for the non-stimulant use. There's also increased ADHD symptoms in children and adolescents. So it is no mystery that COVID was pretty hard on kids. I think everyone has seen that, and kind of it's very sad. You know, virtual schooling, household economic stressors and quarantine orders can really exacerbate these symptoms, where they might have benefited from being in school, having a structured schedule every day instead. There's also increased access due to a flexibility to prescribe to patients via telehealth without in-person evaluations. And you can also, because of that, you can get out-of-state prescriptions. So you can have someone in Florida prescribe your medication while you're in North Dakota. So it does increase the availability of providers to be prescribing these medications in the first place. Amphetamine-based prescriptions, we saw an increase in those way more than methylphenidate for unknown reasons. They didn't touch on that in the study. And I did want to point out that more than 90% of ADHD medications are being prescribed from either primary care or from an advanced practice practitioner, so nurse practitioner or a PA. So psychiatrists, like the physicians that are prescribing the ADHD medications, they've actually declined in how much that they're prescribing because of the proportion of the other groups going on. And of course, there's the other side, which is decreased supply. So it's quite a bit of a blame game. The DEA and the FDA blame the manufacturers because they give them a quota every year of how much they can produce. And they say, well, you're not producing the maximum amount that you're allowed to produce. Insurance companies might require step therapy, as we kind of mentioned with the viloxazine and atomoxetine, where they might say, you need to try the least expensive option first. Or you can only go to this pharmacy, or you can only use brand name. All of these restrictions on the patient and from their insurance program, which is again meant to save money, but it can be very, very devastating for a patient who really needs a medication and has to jump through so many hoops to get it. In terms of shortages, drug shortages, Zenzetti and amphetamine was actually contaminated with an antihistamine lately. A lot of it had to be recalled. So you can imagine having a medication that can cause a lot of sleepiness being contaminated into your stimulant medication, how that might not work out very well. Lisdexamphetamine, we touched on this a little bit. So there's multiple generic companies that have been approved to make it. However, it is very hard to just start mass producing a medication that you've never made before. So it's largely unavailable except as a brand name product. And again, a lot of insurance companies are saying that they want to use the generic. So they are effectively decreasing the supply, and it's effectively unavailable to a lot of the patients. Possible solutions until supply can meet demand. So some of the things that can maybe help your patients is to prescribe electronically. So instead of writing out a paper prescription and saying, take this to this pharmacy, and then if they don't have it, take it to another, electronic prescribing is faster because the pharmacy can contact you directly and let you know how many they have in stock or if they have any in stock. It's also quicker for the patients or the patient's parents to just call the pharmacy that it was sent to and say, are you able to fill this prescription or not? Instead of going there, waiting in line, talking to someone, having them input the prescription. It's a lot faster if you can do most of that electronically. And then if they do say, we don't have enough to fill this prescription, asking them for a partial fill. So if they have, 24 tablets out of 30 that you need for the prescription, you can ask them to just fill the 24 tablets. They will have to forfeit the other 6, but that can get them through for most of the month, and then they'll just need another prescription earlier on. Mail order pharmacies, which are associated with some insurance plans, may have better availability because they aren't as restricted with the individual DEA requirements per pharmacy. So the DEA says will limit the amount that pharmacies can order, even if they have, the patients, even if they have the demand. The DEA can put a cap on how much of a certain controlled substance that you can order in a month. Looking at the patient's formulary, this one's a little bit trickier because different insurance plans have different formularies. And even within the same insurance plan, they have tons of different drugs that they will or will not allow. But doing that to look for therapeutic equivalents, to maybe seeing, oh, they don't cover, brand name this, but they cover generic, generic of the extended release product. So like if they cover brand name Ritalin LA, but they don't cover generic and only generics available, you can switch to another combination extended release product that might have similar efficacy. In conclusion, guidelines largely recommend medication as a part of ADHD treatment, specifically stimulants. As I mentioned, the ADHD medication options have not changed. Formulations have multiplied, but again, same drug, different packaging. Generic availability has easy ability to access in some situations. In other situations, like for the lisdexamfetamine, it's actually been a barrier for a lot of patients. And then increased flexibility in dose timing. So a lot of these extended release tablets and capsules are meant to be designed so that you can take it once a day, so that you don't have to, keep taking a burst, an as needed medication during the middle of the day when most people are forgetful and tired anyway. Shortages are an ongoing problem, and you may have to try a few different strategies to get your patients their drugs. Hopefully switching between different amphetamine dosage forms and different methylphenidate dosing forms can be a solution. Here are my references. Are there any questions, or should we go on to the case presentation?
Very technical presentation for the prescribers. Are there any questions that people can unmute themselves, or they can put them into the chat? I've not seen anything come into the chat.
Go on to the case presentation.
All right, so the case presentation is AB, a 12-year-old male with a ADHD diagnosis based on the following symptoms present for the last few years: difficulty remaining focused, that mind in the clouds, kind of persona, doesn't turn in work on time or doesn't complete projects, easily distracted, and maybe making careless mistakes. He does get in trouble in class and avoids homework, kind of seems like he has ants in his pants, really can't stay in his seat, blurts out answers, interrupts the teacher, and then he also, they call him a motor mouth, he just won't stop talking. So AB received some early intensive behavioral intervention services and has weekly check-ins with his parents and teachers to address his concerns. So they had been leaning on these behavioral therapies and really trying to avoid stimulant use towards the beginning of the year. But it's gotten a little bit worse, and he's fallen behind in his classes. He was started on a methylphenidate extended release form that has 30% immediately released and 70% released over the rest of the day. This is the fall school schedule. Breakfast, taking the tablet before, or the capsule before leaving for school. Math, geography, biology, lunch, language arts, gym, ride the bus home, have a snack, and start homework. Unfortunately, in the spring, these two switch, so he has gym first thing in the morning, and math is one of the last classes of the day, which is also his hardest. Because of the schedule change, he's a little fidgety towards the end of the day, certainly, and needs reminders to stay on task, hard for him to stay in his seat. He's falling farther and farther behind as the semester continues, and he's embarrassed to ask questions for fear of being made fun of. His teachers have brought up these concerns at the last few weekly check-ins. His parents are open to making a change and would like options for what to choose. So which of the following medications options would you present? And what other information would you want to know before making a change?
Feel free to unmute yourself, or go ahead and use the chat feature.
Any brave spirits out there today that want to take a guess? So in the chat, add IR 10 milligrams at lunchtime.
Yeah, absolutely. So that's a good option. If he's having more difficulties towards the end of the day, it might be easier to just add a little boost at lunchtime so that it can get him through. In terms of the other medications, you could certainly switch to an amphetamine-based product. But it seems like this medication is working for him. It's just not when he needs it. So all of these options could happen. I can go through the other ones if you're interested, just to kind of show the thought process behind it. So we could change to, we could add the, bump at lunchtime. That would be a good, reasonable intervention. Could also change to that triphasic or the kind of the 3 bumps, methylphenidate extended release, just so that you get extra coverage towards the end of the day. There's the Jornay PM. So you'd start with a capsule of 20 milligrams at 8 p.m. every night, and it would be kicking in once he comes in the morning. It might not help with his increased symptoms towards the end of the day, but it could be a different option that he might respond better to. Certainly, you could add guanfacine ER extended release to help with that hyperactivity and impulsivity. Although he does have gym as his first class, so he might not need the extra focus or a suppression of his hyperactivity and impulsivity if he's able to kind of run it out earlier. Another option would be to switch to atomoxetine, a non-stimulant, but again, he doesn't seem to be having any difficult side effects with the methylphenidate. So since stimulants do have better efficacy and are considered more effective for ADHD, you might just want to stick with what you have. One other thing I wanted to mention is that it's unfortunate that we don't have much control over his schedule. So even just the change of gym and math, just that switch can be really devastating to a kid and their schedule. For someone who really relies on that to, be able to have their energy, get their energy out, either at the beginning of the day or the end of the day. That's all I have. Are there any questions?
Again, feel free to unmute yourself or use the chat feature for a question.
And would you be open to questions regarding anything other than the ADHD medication?
Sure.
Just a medication question in general for mental health, or supplement usage. We've talked about that in previous discussions as well.
Yeah.
Not hearing any. Nothing in the chat yet.
And just a reminder, and you probably saw it, but the evaluation and post-test are there too, so please fill those out.
And I also added a reference into the chat during the presentation. It's an ADHD medication guide from the American Academy of Child and Adolescent Psychiatry that can be shared with caregivers for youth that goes through some of the medications. Here's a random question, as stated in the chat. I didn't announce that, but have you seen differences in efficacy of name brand versus generic Vyvanse specifically?
Personally, no, I have not. Since I would expect that it wouldn't have a ton of difference in efficacy because it's all the same molecule. It isn't like it's released, from a coated bead or anything like it is from the Adderall or Ritalin dosage forms. So I haven't seen anything. I mean, these drugs haven't been out for very long. The generics have been out for less than a year. So it's hard to make too many conclusions because there's 4 different companies making them. Anecdotally, though, I have not heard any difference one way or another.
Thank you for that. Comment, this was great. The breakdown of the 3 levels was very nice to see and to how they can be modified and used to support each other and the patient's focus is need. I think that it was good.
Great.
We have discussed, there's many parents that I know, collectively prescribers that I know that are talking about the shortages and how to cross over and how to best meet the needs for kids. And even the anxiety of caregivers who have like found the magic medication that is working, they're having success, they're, doing well, and then they can't get the medication, and the anxiety it creates for caregivers to try to get that medication, and what's the best thing providers can do to help cover some of that. So I think it was good, and this information was good to relay some alternatives.
Yeah, I mean, I know it's really tough. It really just is like the toilet paper shortage. You just want whatever you can get. You don't care about anyone else getting their medication. You want to get your own. You want to get your medication for your patients. But it does take a little bit of creativity and finagling in order to do that sometimes.
My son is currently working through medication options, and it had definitely been a struggle to find the right fit. Thank you for the great information.
Yeah, you are so welcome. I really hope that this information can help at least one person. It's such a frustrating situation to be in. So I do sympathize. I see patients who are like, well, I'm not going to die without my stimulant medication, but I'm not really able to, function in school or work. And it can have really devastating effects on their lives. And I think, Jen, as you said, the anxiety about not being able to get a medication, or the anxiety about, having it be available one month but not the next, and having to maybe switch medications, that can be very significant. And it really weighs on the patients, which is super unfortunate.
Yeah. I think once you find that medication that seems to hold him over through, because the school challenges are a very real piece. If it's a behavioral disruption, if it's a time they can't be in school, or it's a relational issue that they have with their peers ending, or they're more impulsive. It's so the ramifications of not having it on board. And that's, I think, because of the history of people who have been on the medication, they find that one that works really well. Parents are, it is succeeding. And then there's this disrupt that was unanticipated. So that creates that anxiety.
Yeah.
Excellent. Everybody keep doing the wonderful work you're doing. Help our kiddos, our youth, and even young adults that are out there with this. Thank you for your presentation, Dr. Bishop.
Yeah, thank you for the presentation and for participation, and great information.
Happy to help, and certainly feel free to email me if you have any further questions. I'm happy to answer more individual questions as well, since I know there's a lot of situations that can come up when you're treating ADHD.
And interestingly, Dr. Bischoff is a board certified psychiatric pharmacist. So specializing not just in pharmacology, but just in psychiatry, pharmacological intervention. So I think it's just a nice stand apart as we work towards understanding and prescribing more uniquely towards that mental health for pediatrician and for pediatric practices. So thank you for honing into that subspecialty of your practice.
Yeah, absolutely. It's my heart just goes out to any kid that's experiencing any psychiatric illness. It's very tough to watch, and definitely one of the sadder parts of working in psychiatry.
Yeah. Yep. All right. Thank you so much, everyone. Have a great rest of your day.
Thank you so much.
Thank you so much.
Have a good day.
Bye.
Bye.